Now, patient present with increased AP diameter, okay, and then
Uh-huh.
they have dyspnea. That's the most important thing. And there's wheezing, chronic smoker. So, what's
Mm-hmm.
your differential? Could be here.
COPD.
Yeah, COPD. That's most
And
important thing.
just,
But
yeah.
we gotta rule out. It could be CHF, could be
Mm-hmm.
PE. Okay,
Right.
could be MI.
Right.
Okay, so how do you know? For COPD, you want to do peak expiratory flow rate. That's an important thing here.
Mm-hmm. Mm-hmm.
Pulmonary embolism, you want to do ABG here, important for hypoxia. Okay, MI and heart failure, you can do cardiac enzymes.
Mm.
Okay, if there's high suspicion, and then you do the cut gleam, our favorite mnemonic. Okay, now the management, it's a management case. It's very important. The treatment for it is very important and you can relieve suffering of a patient. So now if we have acute management, that's what we have. We have acute management. So the acute management, this is how we start. We start with giving oxygen, give him albuterol,
Okay.
give him ipratropium, okay? And then PO steroid, okay?
Right.
That's for everyone. You start off with that, okay? If severe enough or didn't improve after that, and then also monitor pulse ox and peak expiratory flow rate. Okay, if every 2 hours or every 1 hour, you see if the peak expiratory flow rate didn't improve, then you give IV steroid. Okay,
Okay.
okay, and then you add antibiotics too. What antibiotics do you add? If outpatient, what antibiotics do you give?
Mm, um, I don't know. Which one would you give?
TMP,
I mean,
SMX, or doxycycline if it's outpatient.
ah,
Okay,
okay.
if it's inpatient, then what antibiotic do you give?
Ceftriaxone
You can
or
give levofloxacin,
uh,
moxifloxacin.
okay.
Ceftriaxone is fine too.
Okay.
Ceftriaxone, cefotaxime.
Okay.
Okay, so those are the antibiotics.
Mm.
Okay, what if antibiotic didn't work? If
If
no
that
improvement, okay,
okay. Yeah. Then you intubate them, I guess.
then you do sputum culture first before you intubate them. Like you intubate them if there is severe, like peak expiratory flow rate really low.
Okay.
Okay, so you do sputum culture,
Hmm.
and then now this is very important even for the MCQ. Non-invasive positive pressure ventilation. When do you do that?
Um.
If the PaCO2 more than 45 or pH less than 7.30. Okay, that's what you do non-invasive positive pressure ventilation. When do
Hmm.
you admit to ICU or intubate?
When they can't breathe anymore.
Yeah, when respiratory distress, okay, respiratory acidosis,
Hmm.
okay, hypoxemia, severe hypoxemia, okay. Now, when do you admit to the inpatient?
Well, in acute exacerbation, you would admit them, right?
Yeah, but not any severe. Sometimes severe exacerbation can be treated as outpatient, as emergency room. I mean, but if it's severe, if there's severe dyspnea, okay, can't eat, then you admit it. Okay, if there's worsening hypoxia, okay, increasing PaCO2, then you admit them. If there is respiratory acidosis, you
Mm.
admit them. Okay. If there's altered mental status, you admit them. Those are very important. Another thing important, if there's comorbidities, Like what? Like if there's arrhythmia, okay? That's
Mm.
an important thing. If there's CHF, if there's renal failure, if there's diabetes,
Mm.
okay? If there's liver failure, okay? You admit them.
Mm.
And also, if there is failed outpatient management, you admit them too. Okay?
Mm-hmm. Okay.
So now what else we manage him? Like we do the peak expiratory flow rate and monitoring. So if the peak expiratory flow rate
Mm-hmm.
return to baseline, okay? What do? We give him influenza vaccine
Mm-hmm.
and Pneumavax PCV or PPSV 23.
Mm-hmm.
Pneumavax, that's how you type it in the software. And then you counsel smoking cessation, usually smoker,
Mm-hmm.
okay? And discharge home, okay?
Mm-hmm.
But if the peak expiratory flow rate didn't improve, okay, then okay, you admit, you switch PO steroid to IV steroid, okay?
We would admit to inpatient unit,
Yeah,
regular.
yeah. If it's in the emergency room to inpatient, okay? You give albuterol, ipratropium. You can switch it to medium dose inhaler, okay? And you assess home oxygen need. When do you give home oxygen?
When their PO2 is 50%.
Yeah, this is very important. If the PaO2 less than 55 or the SaO2 saturation, it's less than 88%.
Ah.
Okay, so those values are very important. So in a summary, patient present with increased dyspnea,
Wait,
chronic
home
smoker,
for home oxygen, what was the criteria again? PaO2.
less than 55 or SaO2 less than 88.
Okay.
Okay, so now to summarize everything, increased AP diameter dyspnea, we do peak expiratory flow rate, APG, cardiac enzyme, cataglene, maybe some of them. You start with albuterol, oxygen, steroid, and antibiotic, levofloxacin if it's inpatient, and NIPPV if the PaCO2. So those are criteria I want you to remember. pH less than 7.30, PaCO2 more than 45, you do NIPPV. Okay, you
Mm-hmm.
intubate if there is respiratory distress, acidosis, hypoxemia. Admit if there is severe dyspnea, can't eat, worsening hypoxia, arrhythmia, CHF. If improved, then you influenza and counsel.
Mm-hmm.
If didn't improve, then you assess home oxygen need if the PaO2 less than 55, SaO2 less than 88. Okay, you switch to IV steroid and you admit. Okay,
Mm-hmm.
that's a summary of COPD exacerbation.